So I'm going to be talking about tiny eyes and towering risks. So operating on tiny eyes is like that you have to navigate really, really cautious. You don't have a time to react and you have to stay focused. And ultimately, when you really succeed, it is a celebration which you would never forget. So with that, I would like to start off. So tiny eyes are generally considered as nanophthalmic eyes. It's a rare developmental disorder with structurally normal eye, but a smaller axial length of less than 20.5 with a retinochoroidal scleral thickness of more than 1.7 millimeters. So the basic characteristics here are shorter axial length, high hyperopia, and increased scleral thickness, which pose significant surgical challenges in these eyes. And the most common association is angle closure glaucoma. So the reported association of angle closure glaucoma in these eyes is around 50 to 70%. And anatomical characteristics of the eye relatively leads to a pupillary block because of the high lens-eye volume ratio. There's also another mechanism where they can have an angle closure. That's basically because of a spontaneous choroidal detachment, which can cause a secondary angle closure because of the forward rotation of the ciliary body. So there are two mechanisms. One is a primary angle closure component as well as a secondary angle closure. So these eyes are often considered as nightmare by most surgeons. None of the surgeons want to touch on these eyes. They just tend to refer to elsewhere. I think it is a good thing to do that because you need a good backup of a retina facility to tackle any intraoperative problems that could happen. So these are nano eyes and they cause macro problems like suprachoroidal hemorrhage, flat chambers, choroidal effusions, choroidal detachments, retinal detachments, and malignant glaucoma. So there are certain management pearls which would help in avoiding such complications. So first of all, you have to first do a good preoperative workup. You have to label them as what is needed for them, whether they need the control of intraocular pressure, when they need to handle the cataract or to manage the uveal effusion. So generally classify them as open angle with normal intraocular pressure, which is very rare to have an open angle. You can just observe them, but some of them may have an open angle as well. So others who have predominantly a narrow angle, it is mandatory to do a laser peripheral iridotomy in these eyes. Look at the retinochoroidal scleral thickness, look for any subtle signs of any effusions. Then if such things happen, it is important to start off on preoperative systemic steroids to reduce the effusion and decide on the need for sclerostomy. The cataract occurrence is usually in the middle age, and then that is the time when there is more association of glaucoma as well. So these younger adults of more than 40 with narrow confines and a cataract which is progressing is the most troublesome ones. So here we have to decide whether we have to do a cataract surgery or a sclerostomy, depending upon the severity of either the cataract or the uveal effusion. So whenever we plan for a cataract surgery, it's very important to plan only a close confined surgery, like a phacoemulsification surgery, because with the modern day phaco techniques, we have a good system where we could maintain the pressure inside the eye, we could maintain the chambers always. And it's important to also do a goniosyneculasis in these eyes. And decision on sclerostomy will be made on certain parameters, which I will be sharing a little later. The other common thing is uncontrolled glaucoma. So there may be some patients who do not control intraocular pressure in spite of maximum medications. So it's important to channelize them as to what has to be tackled first. It's better not to combine the surgeries together because of the high risk of complications in these eyes. So what I would do is I would first look at the problem, which is more severe. So if the glaucoma is what is more severe, then I would like to tackle that first. So either I would do a diode, get the pressures normal and then take for surgery, or I would do a stage procedure depending upon which is necessary. So generally, I do a good preoperative workup. So all of the planning is something which is very, very essential. So you have to do a good preoperative workup to understand what are the things that you're going to do during the surgery and what steps you want to take, what kind of surgery you want to do. So IOL Master is one beautiful tool where you can get a lot of information in just one test. So basically, you get the axial length. You also can get the anterior chamber depth. You get the lens thickness, and of course, the IOL power. It's important to also do the anterosegment OCT because we want to know the lens vault. We need to know the iris thickness. We need to know the chamber depth, which has a better objective documentation with an ASOCT. B scan is mandatory because the diagnosis itself is like axial length less than 20.5 and RCS of more than 1.7. So anything which is more than 2 millimeter is really very notorious to go without doing a sclerostomy. Macular OCT is also very useful to understand what would be the visual outcome, because most of these patients are associated with foveal hyperplasia, or they do have a high hyperopia with amblyopia associated during their entire childhood. So they may not be good visual outcomes postoperatively. I follow the 4S strategies. So what is the 4S strategy? Number one is steroids. So basically, these may have some amount of subclinical effusion. So it's better to start off on steroids, topical steroids, at least a week before the surgery. The second is most of them have secondary angle closure. So I prefer to treat them with iridotomy 2 weeks before the surgery and put them on steroids. The third thing is, again, a soft eye, maintaining a soft eye. So this is very, very useful by doing a intravenous mannitol infusion to dehydrate the vitreous to avoid any posterior pressure during. The fourth is sclerostomy. So doing a sclerostomy, again, it depends on certain parameters, which I would tell a little later. There are certain other intraoperative pearls which also would be helpful in avoiding complications. Like already mentioned, phacoemulsification is definitely a better way of doing operating on these eyes than a small incision cataract surgery. Better to have valvular incisions or bimanual IA, use a high molecular weight viscoelastic, and do a soft shell technique. It's also important sometimes to maintain the anterior chamber continuously by using an AC maintainer, and always understand that you need to visualize what you're doing. Most of these eyes are associated with angle closure and they may have a smaller pupil. It's important to dilate the iris using iris hooks or retractors. Dilate the pupil using iris hooks or retractors. So with that, I would just walk you through a case. So this is a 45-year-old male who presented with significant cataracts in both the eyes. Patient had a defective vision in both eyes for past 2 months. His refractive corrections were as shown here, 1/60 in the right eye and 1/60 in the left eye, which was improving to 660 and 618 with a very high hyperopic power of +11 and +12. Intraocular pressures were 16 and 15 in right and left eye. Patient had shallow chambers as seen here. Gonioscopy showed closed angles. Fundus showed a hyperopic disc with a serous RD in the right eye, and there was a near mature cataract in the right eye. So looking at the parameters with IOL master, you see the axial length is around 15.3 in the right eye, 16 in the left eye. Look at the RCS thickness. It's very, very thick, which is around 2.8 and in the right eye and 2.12 in the left eye. So with this, a diagnosis of nanophthalmos with secondary angle closure in mature cataract in both the eyes with a serous RD in the right eye. So we decided to first operate the burst eye. So the inferior sclerostomy was done in the inferior quadrant by a retina surgeon. So once you visualize well after bridling the two muscles, then you raise a scleral flap, just like a trabeculectomy scleral flap, around 4 into 4 millimeter, which is as close to the vortex vein. So a superficial scleral flap, after it being raised, a deeper scleral flap of 2 into 2 millimeter is resected out, exposing the underlying choroid. So once this is done, it's important to cauterize the edges of this flap so that it remains patent. So this acts as a window. So whenever there is any associated collection of effusions, it would drain through that. So once you do this, the eye becomes soft, and then we can proceed with the temporal cataract surgery. But the procedure itself has to be really very quick. You have to get everything in place. You don't have time to even react a little here and there. So what is important here is just when you're placing the lens, it's important to extend the wound because these lenses are really bulkier. They're more prone for breakage. So once you do that, it'll facilitate a smooth placement of the lens. So this is the postoperative picture. So what seemed was really very, very difficult. The postoperative outcome was also very good. So this patient was really happy with the right eye. He came back for the left eye. So left eye, again, we followed the same, though left eye was relatively a better eye compared to the right eye. So then the left eye did not go so well like the right eye. So there was a lot of struggle in spite of doing a sclerostomy. I had to really struggle getting into the eye. There was sudden increase in posterior vitreous pressure. So I had to do a little bit of vitreous tap there to allow me to complete the rest of the surgery. So once that was done, the eye became a little soft, then completed with the Simcoe aspiration because each time I was taking the probe, it was just getting the iris into it. So with great difficulty, after the cortex was washed, the lens is being placed. There's a lot of struggle to put the lens in the bag here. So I used another side port and very gently using the cyclodialysis spatula, I was trying to push it inside. So there was a lot of manipulation, a lot of iris pigment release. It was not an easy surgery to say that. So post-operatively, as expected, it didn't go so well. There was some amount of effusions, which we actually treated with steroids and atropine and waited for a couple of weeks. But again, there was no resolution of these effusions here. So then we decided to do a drainage of this. So this was done after 2 weeks. So 2 weeks later, so this is the pre and post-operative picture of the effusion and RD that settled down. So surgical options which were reported in the literature dates back very long. So they have earlier told that quadrantic partial thickness sclerectomies or decompression of vortex veins were helpful. And then there were several modifications which were done, like using an ultrasound guided drainage of the effusions, or even express shunt, which was used for glaucomas, being used for this purpose. And there's also been several modifications in terms of how to keep that window open, just like how we use a mitomycin to avoid scarring. They've also used mitomycin to keep that path without any fibrosis. So the bigger question is, do all eyes need a sclerostomy? This is a very important question, because I wouldn't say that every eye with nanophthalmos need to undergo the sclerostomy, because sclerostomy also has a few complications which one may encounter. So I prefer to do it based on the experience, axial length less than 18, when there is a retinochoroidal scleral thickness of more than 2, when the chamber depth is very shallow, critically like less than 2, lens thickness of more than 4.5 to 5, and when there is obvious presence of a choroidal effusion. Having said that, is sclerostomy the holy grail? Again, even after doing a sclerostomy, because I showed you 2 cases, out of which one case went on very well after doing a sclerostomy, but however, the second case, even after doing a sclerostomy, there was some struggle. So like that, I do face a lot of times problems that may not allow the continuation of the surgery. So this is an eye which became really very hard. I was not even able to use any instrument into the eye. It was literally flat. And every time I was trying to take something inside the eye, the iris was just popping out. So I decided that it's not ideal to continue with the surgery. So here I closed this patient that day. Then subsequently, I had treated with diode and then planned to take the surgery after a couple of weeks. So this is another patient where relatively everything went on well. It was very, very smooth sail until the cataract was removed. And just after removal of the cataract, this is the crucial step when suddenly the pressure becomes very high. And after that, it was very difficult to put in any instrument. So we had to do a little bit of minimal vitrectomy there with a 23 gauge. So that just one step short of completing the surgery, this happened. So then after doing that, the AC deepened and the lens was placed, and it could be completed. So this is a landmark study which had compared the outcomes of cataract surgery with and without sclerostomy in anophthalmic eyes. This was very old, actually. It was in 2017, but this paper gave a lot of idea about doing a sclerostomy. So it reduced the incidence of occurrence of any complication by 80%. And it also showed that SICS had more complications than phaco in both the groups, whether they underwent a sclerostomy or no sclerostomy. So another question is, these patients generally require a very, very high powered lens. So we are actually undercorrecting them because the maximum IOL power available is only 40 diopters. So there is a residual power of around 20 diopters. There has been a lot of reports about piggyback lenses in these eyes. So I try to just see if they really achieve ametropia by giving the full correction. So this is a patient who had a 13.5 axial length and RCS thickness of again 2.5. And a near mature cataract. It was a relatively younger patient, so I wanted to make sure that I do the best for this patient. So here you see that the eye is really very hard. It's shallow even after doing a sclerostomy. Sometimes it is also important to even try if you could do a femto in these patients, because it's very difficult to do the rexus here. So once this is done, I first place the single piece lens in the bag, which is like 40 diopter lens. So the proportion of distribution is maximum power goes inside the bag, like 3/4 goes inside the bag, and the remaining one third will go into the sulcus. So 40 power lens was placed in the bag. This is like a antechamber depth of around 2.5 millimeters. And now I try doing the second lens, which is again a little difficult to push it in that small space and make sure that it sits in the right place. So here it's again a lot of struggle. So this is a 3-piece lens. When you're placing it's better to place a 3-piece lens in the sulcus. So you had to go with the cyclo, depress the lens down and then push this lens inside. So again, there was a little more of struggle. I wasn't sure if it was worth this trouble though. So just another 1 minute, Kavita. So then I could finish this. And then in the post-operative period, though there was a good centration and all that, later there was signs of decentration, pigment dispersion. There was a high chance of secondary angle closure, ventral antichloropacification. So by having seen all of this, I thought that it did not give a good visual outcome as I expected, because they do have some amount of amblyopia or foveal hypoplasia that may be contributing to the vision. So again, complications with glaucoma surgeries are very high. It's better to go for a stage procedure than a combined procedure. And presence of an angle closure and a synechiae increases the risk of glaucoma in these eyes. So tips in glaucoma management is pre-placed sutures, tight closure, stage procedures. Maybe now newer procedures like MIGS may also play a role, which has to be explored. And it's better to go for a diode whenever the pressures are very high. So the take-home message here is nanophthalmic eyes are small eyes. They cause bigger problems. Meticulous preoperative planning, prophylactic sclerostomy, and prolonged postoperative steroids and cycloplegics may minimize the occurrence of complications in these eyes. It's better to go for microincisional surgery with better machines and fluidics, like phagomulsification in a closed system using the Centurion. Glaucoma typically occurs in adults above 40 years, requiring close monitoring. A stage procedure is always preferred over combined procedures, and it is always better to perform a sclerostomy when required. Don't forget to wear the shield. Thank you for patient hearing.